started here. Good afternoon, everyone. We're here today to talk about how San Diego Health Connect HIE was able to double their patient matching rates without adjustments in data quality or data governance programs. Before we get started, though, I wanted to get some housekeeping items out of the way. If you have any questions, you'll see a chat box where you can submit them. I'll field the questions and feed them to our speakers. They'll address your questions at the end of the presentation. If you missed something or want to share this session with a colleague, we'll be recording the webinar and it will be available online after the show. I'll be sure to send that out to you guys as well. So now I'd like to introduce our two speakers, Nic Hess and Joaquim Neto, who are both joining us from the West Coast. Nic Hess is a project manager for the San Diego Health Connect HIE. He works closely with SDHC's participating providers, including members of the SDHC Patient Master Index Work Group, which is responsible for patient identity accuracy at the San Diego community level. Nic has been with SDHC for 2 years, and he's worked in the HIE world for the past 10 years. Joaquim Neto is a senior solutions architect at Verato. Joaquim worked closely with Nic and the SDHC team throughout this project and has decades of architecture experience in information management with a particular expertise in healthcare and master patient index. Before joining Verato, Joaquim worked at Initiate Systems for many years. And without further ado, I'll throw this over to Joaquim to go ahead and start with the webinar. Joaquim?
Excellent. Thanks for the intro, Rachel. Yeah, thanks everyone for joining as well. I was just taking a look at the participants as you guys signed on. And we've got a bunch of, looks like we have a good representation of folks from HIEs around the country. And we've also got some folks from some leading payer and provider organizations, other state HIE organizations, and even some policy-oriented and charitable organizations. So a nice, diverse crew here today, so thank you all for coming. What we want to cover today is to tell the story of San Diego Health Connect. We'll give you a little bit of background on the organization. Nic's going to do that. Tell you about sort of the challenges that they were facing from a patient identity perspective, how their organization was collaborated together to make a commitment to address this patient identity problem across San Diego, and then how we got involved from Verato. Tell you a little bit about the technology we use to address the problem, and then share the results with you. We gave this presentation initially at HIMSS just a couple months ago, and it was well received, so we thought we would go ahead and set up a webinar and kind of expand the audience a little bit. So hopefully we'll get something out of it. And like Rachel said, if you have questions or comments or anything, please go ahead and submit those, and we should have plenty of time at the end to address some of that. So moving forward, Nic, you want to go ahead and kick us off and tell us a little bit about San Diego Health Connect?
Yeah, great. Thanks, Joaquin. Really appreciate it, and appreciate everyone joining today. So just jumping into it here, San Diego Health Connect and what we are. So we're a not-for-profit public benefit organization. So we spun off from the Beacon Grant, which many of you I'm sure are familiar with, offering connectivity to a secure private network, information exchange via integration into existing EHRs, EMRs, or we also have a front-facing portal access for those that don't have that integration, offering secure direct messaging with interoperability, and 100% HIPAA compliant with no grays in there whatsoever. So with that, so San Diego Health Connect's mission is to connect our healthcare stakeholders to deliver quality, comprehensive information for better care. So when you can access medical information securely, all medical information within a community, doctors can provide better care, more informed care, less cost, and definitely better care. So moving on to our area, so our primary area is San Diego County with about 3.2 million people, second most populated county in the state. We also are into Imperial County, not just San Diego County. So some statistics here on this slide of the square mileage and that geographic location, San Diego. So San Diego Health Connect, we actually offer cloud-based federated systems. So we're not a centralized data repository. So we're connecting health plans, hospitals, physicians, public health agencies, all real time with a federated model of pulling back the data when it's needed and accessible directly from our participant base. So given that, why use an HIE? You know, healthier patients, fewer medical errors, more efficient automated sharing of information, less paperwork, better treatment decisions, and better supports of public health. Automates the process of reporting, and we've done some great work with San Diego County and Human Health Services here in the California Department of Public Health. And to give you a sample of our participating organizations, you can see here, here's just a sampling of those. UCSD, Health System, SHARP, Scripps, Healthcare Partners, Southern California, Brady Children, some of the larger players here in San Diego. So with those, from that organizations, with our model, we actually populate our MPI from 25 different provider institutions. We actually receive ADPs for all of those 25 provider institutions, about 3.2 million patients with about 7.5 million transactions a month. So that feeds into our MPI system, which is Mirth Match, where we use an algorithm set forth by our MPI work group, and I can talk more about that later, to actually populate our MPI for our 25 provider institutions across the county. So that populates the MPI, and with that, the MPI currently, the way that the group has set it, we have to match on 6 separate criteria. So first name, last name, middle initial, date of birth, gender, and social security number to be an exact match to populate the MPI between participant organizations. With that, if you don't match on those 6, you go into what's called an exception queue or a potential link. And this requires manual review from both institutions or organizations that patient is considered a potential link if it doesn't match on those 6. So as you can imagine, with the amount of 75 million transactions a month, that queue starts to build. So one of the things we were looking at here, as you can see, ultimately near the end, when pulling on these participant organizations and onboarding, the total time that it would take 2 full-time employees would take 8 years to work that exception queue of 187,000 plus potential links. So we were tasked with, how do we create this? How do we fix this problem? What do we do? So we set out with our work group, which contains about 41 different members across 13 different organizations, having 2 meetings per month on how do we tackle this problem. And one of the solutions, and the one that was most received, best well received by the MPI work group, was a presentation that Verato did. So right about here is where I'll just hand it back over to Joaquim so he can kind of tell you a little bit about the Verato process.
Great, thanks, Nick. And I'm actually going to back up one slide too, and just make a couple editorial comments on the San Diego work group and my perspective on that. So when we originally engaged from Verato with San Diego Health Connect early 2015, when they'd identified this backlog was growing and started looking for a solution to address that. And so I have a lot of experience working with HIEs and solving patient identity environments, both in public HIE and private HIE organizations, and within the 4 walls of institutions. And so when I came into San Diego the first time and started talking to Nick and team, it was really clear that they had to jump on the governance processes for HIE. So all of these members from these different participating provider organizations were really committed to achieving a high degree of accuracy, and that's because as they formed the HIE, they'd recognize that basically the HIE is only going to be as good as the patient identity linkages across the different organizations, and so it was high on the priority list to make sure that when a physician went in to retrieve a historical record or a lab result or something for one of their patients, the community recognized that in order to have the HIE, adoption succeed and to deliver the value that, sort of has been promised, they had to make sure that as many of those interactions retrieving the related clinical data as possible could present themselves to the provider. So I was really impressed by sort of how the group was organized and the commitment to this. And that was one of the big things that sort of led us to being able to, put in place a solution here very quickly, which is what we'll talk through now. So to give you a feel for that, Verato, we sit in an interesting space. The traditional approaches to solving identity problems in healthcare and in other organizations, they're kind of in two approaches. So one is the traditional master data management or master patient index technology approach, where you obtain data from the systems across your enterprise, or in case of HIE, across multiple enterprises, and you pull those records together and you match them kind of one by one. You pair them up, and you try to figure out which represent the same person, and make a decision based on that data that's within the kind of data ecosystem already. On the other side of the equation, historically done for marketing purposes, there are information service providers where you can upload lists of your data and can be matched against known data sets and provide answers to identity that way. And so typically what happens is, on the one hand, the MPI technologies have advanced algorithms, but they're limited in the data they're working with. They're basically limited by the quality of the data that exists in the organization systems today. On the information provider side, there tends to be a broader, more robust set of information to access, but those organizations historically haven't invested as much in algorithms, at least to the degree that, say, the MPI technologies have. So Verato was created a company in 2012, and then we've been really expanding since 2015 for the sole purpose of kind of bridging that gap. So we have a solution that is designed to be both data-rich and algorithm-rich, and that's kind of the secret sauce to addressing some of the problems that arise with matching data, that especially in healthcare, is always thinner or has more errors in it than you would like. So the approach that we have is, when we think about identity, we think about a person's identity as kind of being this series of different graphs. There's a Biograph, which is the typical demographic attributes that you would see in an MPI matching algorithm. So, name, birthday, social security number, things like that. Then there's other types of graphs, things that about people, can know about a person. So relationships to other family members, for example. And then there's other types of attributes that certainly link to people. Things like phone and email are what people commonly think of there. If you expand the universe beyond that, there's actually all sorts of information, especially kind of in today's digital age, that people are associated with individual people. So kind of from our philosophy, we see all these things coming together and telling a big picture about someone. And if you have all that information, then it really changes the way you can go about identifying which records belong to that person, and doing it in a way that you're accurate enough to be used in mission critical scenarios. Healthcare being the best example of that. So I'm sure everyone on this call today is familiar with the data problem. So in healthcare, as well as other industries, there's all kinds of reasons why data is messy or becomes messy. So everything from the typical data entry errors that happen in registration systems to aging of data over time. So people move and then addresses become out of date. There's numerous types of ambiguity when you're looking at relatives that can share certain pieces of information, sometimes share the same social security number, things like that. And then there's other life events that happen too. People get married and change their names. And all of these things add up to kind of making a mess of the data that, if you're responsible for data quality, it becomes very hard to overcome. So the way Verato tries to address that problem is we basically bring more data to the equation in an attempt to overcome data problems that might exist in your systems. So we have what we call Carbon, which is essentially a reference index of all the people in the U.S., adults in the U.S., as close as we think anyone has gotten to a comprehensive listing of that. And we've built that out of data from a variety of different data sources, very explicitly chosen by our data science team to provide both kind of a rich data set in depth. So when you look at our data, a very high percentage of our records have all of the demographic attributes you would want to resolve someone's identity. So name and date of birth and address and SSN. It's not spotty with lots of holes like we usually see in our clients' data. And then we augment that with data from other sources that validates the information we have, fills in what gaps are there. And so by doing that, we've been able to create this data set that it's wide, it has lots of attributes, but then it's also very deep. So we have information as it changes over time. So if you change your name, we get a legal record and we see that name change, and we keep both those names on file. And therefore, if you present in different facilities over time, we can kind of see through the fact that you might have different names on different records, but they really represent the same person. That's kind of the idea behind our approach. So from a slightly more technical perspective, a way to think about it, if you're familiar with the sort of traditional MPI approach, the deterministic and probabilistic matching algorithms usually take a record from one system or one record in a given system, and they compare that to another record and do kind of an attribute by attribute comparison. So if you think about the little balls on these Tinker Toys as being different attributes, on the left you might have a record with a name, a date of birth, and an address on it. And on the right you might have a record from a different system that has different data entry requirements, and it's got a name and a social security number and a phone number, but the address is missing, something like that. With the traditional probabilistic technique, no matter how good the algorithm is and how much fuzziness you have built in, if the attributes just don't line up against each other, there's no way to recognize that these two records represent the same person. So the way we try to overcome that is we take those same records, we match them up against our reference information, carbon. The first record might match on one set of information, second record might match on a different set of information, but because they match the same carbon identity that we're tracking, it becomes a clear decision that these are the same person. And that helps us overcome all kinds of issues that you see in data in these systems today. So moving, kind of circling back to the San Diego Health Connect work, Nic introduced the idea and explained how this queue of tasks had built up as an exception to the MPI processing. These were things where there was some pieces of information in common between two records, but not enough for the algorithm to say, yes, these are definitively the same person. So what we did is we started this whole effort by taking that backlog, that queue, that was going to take more time than was available for people to work manually. And we ran that through our process, the broader process. And the results that we got is that of that 187,000 record queue, by bringing new data into the equation, we were able to resolve 142,000 of those tasks. So basically 75% of those tasks we were able to compare against carbon, in the vast majority of cases identify that, yes, they're the same person. In some cases identify that they're actually different persons. So if two records in one of these tasks ended up being for a husband and a wife with sharing a social security number, for example, which is something that very often gets put to the queue in an MPI, we're able to clearly identify those as two separate people. So we can resolve the task both as, yes, they're the same person, and then in some cases, no, they're different people. So the outcome of that is that SDHC was able to take those results of those decisions, process them in the MPI, and reduce that backlog from a kind of insurmountable 187K down to 45,000 remaining that were still to be worked on at some point. One of the other just comments I'll make, so when I introduced carbon and kind of explained where we get our data, it's a variety of legal and commercial data that comes from how people interact in the financial world and in the public world. So obviously we don't have from those data sources a lot of information on children records. So when we look at this 45,000 that we didn't resolve, the majority of those were related to pediatric type records. We talk a little bit more information on what we do with those records, but needless to say, we don't get the same benefits from the depth of information we have in carbon as we do for the adult records, and so that's where those remaining ones sit. There's something other. The next step we did, which was interesting, was we said, okay, we were able to resolve, the significant majority of tasks. Are there other records out there that are false negatives, 2 patient records that should be linked together that just didn't even make it into the queue? So the way most MPI systems work is they have a process for kind of identifying which records might be the same person, and then some scoring to see if they do or not. Sometimes the data quality errors that exist in data are so significant that you don't get records even put into this, bucket to be evaluated when you're going to look in the database to see if there's other patient records for the same person. So we said, are there records that didn't make it into the queue that also should be linked together? And to do that, we analyzed the entire 3.2 million record population and found an additional 126,000 linkages that needed to be made across records to provide the complete clinical view of these patients. So again, the same technique that I talked about before, but this is looking beyond the things that were already identified in the queue and kind of assessing the entire patient record data set. So when you add those two things together, the queue that we reduced by 75%, and then the additional matches that we obtained by identifying the false negatives, the net result was, basically a doubling of the links in the environment, which was a really, really significant result. So a few other things that we did at the team in San Diego, they're pleased with the results of that and the linking of the records. And they had some additional questions, trying to get to the underlying cause of why kind of the traditional approach wasn't able to identify these things that we'd found. So we did some additional profiling. We looked into the scenarios where Verato had found a match that hadn't been found by the on-premise system in place, and did some profiling and found some of these sort of interesting statistics. There were 1.3% of the records had different birth dates on each half of the potential linkage. Obviously, one of those is wrong. It's not both of those. There was, as you might expect, but it's interesting to just see that 7% had different last names. Some of those are typo type things that certain fuzzy algorithms can catch, but others are simple name changes. And if you look at the stats of how many people get married a year, and then likewise how many people move a year, you're going to have these differences in name and address that can't be overcome without kind of bringing that additional information to bear. So overall, just these sort of 3 typical errors that are usually critical parts of matching algorithms. A fifth of the records had at least one of these, which basically meant that you really had no chance to get the answer without bringing some new data to the equation. So with that foundation of identity, the group in San Diego, and this is what we're seeing with HIEs all across the country, which is why we wanted to sort of focus on the HIE use case here in this webinar, is that everyone understands that HIE is dependent on having technical interoperability, and so there's been good adoption of standards in healthcare, obviously, and plenty of debate on existing use of HL7, version 2, version 3, the new FHIR standards that folks are really excited about and starting to get some traction. So while there's some controversy and difficulties there, there's actually a really good foundation of that technical interoperability. Folks over the last few years have been investing a lot also in interoperability standards around code sets and things like that, which is also obviously critical to aggregate records and understand how to rationalize, the way different diseases and procedures and so forth are categorized in different systems. And then the third kind of leg of the stool on this idea of, standards and interoperability is recognizing which of these records belong to the same patient. So all of those things kind of are sitting on top of that foundation of, do we have the right complete view of the person? So that's what we're trying to enable here, and San Diego is trying to do, is to build that foundation of, as close as you can get to, the Chime patient matching challenge, which is seeking the 100% accuracy we're all striving to get as close as we can to that as possible. So the team at San Diego, when we finished the project, did some kind of ROI analysis for themselves. So Nick, maybe I'll hand back to you and let you comment on kind of your findings and what you reported back to your community about the project.
Great, thanks, Joaquim. Yeah, so as Joaquim was saying, so it definitely lowered the cost, a higher quality of patient care. We did some numbers on this and took a look at the savings around it. And one of the biggest ones that we saw was definitely less manual data stewardship. So basically that number of potential links or the exception queue and that amount of time that it took for someone to actually work those, because right, you're having, depending upon how many patients was seen at a different organization, it required 3 to 4 different representatives from each organization getting together, verifying if this patient was actually the same. So Verato came in and reduced that by 75%, which was a huge number. So it cut that potential link queue down by 75%. It definitely reduced the time for onboarding providers and hospital organizations by 20% as well. Coming in with the clean data, we would get their backlog of patient lists, and it reduced the time in patient matching and just definitely saved us a lot of time when onboarding new providers to the HIE. And here are the numbers here. So that 75% dropped the queue there, and then definitely 20% less time on onboarding, which was a huge saver when we bring on these larger hospital organizations to reduce the cost in our time that it would take to onboarding, and then the cost reduction for providers and hospital organizations not having to take the time to actually work that manual queue that was out there, that exception queue.
Yeah, and I was just going to make just another comment on that too. Is that's kind of a recurring theme that we see too. Is kind of like as HIEs and not just public HIEs, but the concept of HIE, the verb HIE, health information exchange across participants, regardless of whether you're using a public HIE or a EMR to EMR connection or anything else. It's the more successful that organizations become in establishing exchange of information, then they start to get more traction, they get more participants coming on board. You start to get, once you've got all the provider community or a certain amount of the provider community together, then you start to get, payers and other organizations coming in, and organizations get to this, tipping point where, hey, all of a sudden we're really onboarding kind of massive amounts of data. And in some cases, you start to onboard data that sort of by definition has more overlap in the patient population, and it just becomes more of a challenge to be able to process all this stuff and keep your level of accuracy without false positives, limiting the false negatives. That problem just gets harder as you get more and more adoption. So we're kind of seeing that a lot with organizations that are getting to this point and saying, hey, we're really successful now. We're starting to onboard lots of organizations, and every time we do, we have this huge chunk of work, or we see this big backlog and identity problems. So it's definitely a common thing that we're seeing, which is good. It's a good problem to have. As adoption grows, you'd rather have that problem than the problem of not having the adoption. So, kind of being a little tactical, we talk with organizations and folks that have heard the San Diego story and some of our other use cases. Often, trying to picture how to start, working with Verato. So if you're an organization that has an MPI, most, HIEs do have an MPI or at least a record locator service concept, then it's kind of it's a very quick win to figure out whether you have this kind of backlog that is, conducive towards automatic resolution. And so far, all the ones that we've seen have. So we're very happy to do kind of short proof point projects where we take 10,000 tasks and go ahead and run them through our automatic stewardship process. and give you those results and let you see kind of what impact that can make. It's a pretty straightforward process, and you know, we invite folks to ask us about that if it's something you'd be interested in. So I think we definitely have some time for some questions. So Rachel, I'll kind of flip over to you and see what questions we've got out there for either Nic or myself.
Sure. The first question is for Nic. The audience wants to know, how did you verify the results of this approach, since it is a little different than typical MPI matching?
Oh, yeah, definitely we did a lot of verification. So our MPI work group, I think we've mentioned a couple times in this, really was the voice in all this. All those organizations that attend that work group were set with the task of actually verifying all of the work, and they basically said they wanted to verify it before they would agree for us to run anything against our MPI or our databases. So the first run was originally with the potential link list only. So when we got the data back from Verato, we took samplings out of that. We had about 10 different live working sessions with 2 to 4 participant organizations on the phone doing a WebEx at the same time. And the MPI work group had already established a set of processes in order to verify the potential link list. So it went against that. So essentially, we had 2 to 4 different organizations on the phone at the same time, pulling up the same patients that Verato said, yes, these in fact are the same patient, let's merge those. So we were at those working sessions, each organization was pulling different documents, looking at signatures, government-issued IDs, past information on addresses. So there was a really strict process. So on those working calls, we went through nearly 50 to 100 different records, and we did that 10 different times, and that was just on the potential link list. On the second time, when Verato, we did our full MPI, because our algorithm is so strict, having to match on the 6 points that I talked about earlier, they have to match 100% on that, or they weren't considered by our MPI a match. So Verato was taking the rest of the MPI that didn't even hit that potential link queue or come close to it, and saying that these were actually in fact a match. They were a lot more strict in reviewing those as well, because they were a little apprehensive about doing that against our full MPI. But after having those additional working sessions, that second round, they were really confident in running that through our MPI, which I think we had a slide in there that showed that increased by 120 additional thousand matches. So I hope that answers the question.
Yep. Yeah. That's a great answer, Nic. And Nic and team, and really it was really the representatives from the individual providers. They definitely put us through the paces on that review as any other organization has, which was we appreciated that.
Yeah, great. Next question. This one is for you, Joaquim. What other matching algorithms do you use to identify the false negative rate of the Verato matching algorithm? If you do not use other matching algorithms, how did you ascertain the false negative rates?
That's a great question. That's an awesome question. I love that question. I'll try to answer it, limit myself on the time to answer. But yeah, so that's a great question. So what's kind of unique about the way we've engaged with a lot of clients, and San Diego Health is actually a good example, is that many clients have a baseline from an MPI or an MDM system. So when we did this project, just kind of staying with this as the example, we were able to look at the queue, the backlog queue, and we know how many of those we addressed, the 75%, we resolved definitively as either yes or no. And we also know the portion that was left that we couldn't make a decision on. So we basically, from the answers we got on the yes and no decisions that we did make, we're able to estimate amongst the rest of that queue what in reality is the likely number of those records that represent the same person, where even we didn't have the extra data to confirm it. So it's not a decision that we could automate or an MPI could automate because the data is not there to do it. But based on that data that we did have, we were able to estimate the portion of those unknown matches that were remaining that we think were the same person. And we estimated basically at the bulk of them. That's something we see with most MPI and MDM implementations, is that they're pretty good about getting things into the queue that are likely matches. When you look at the percent of tasks that are resolved as positive, both the way we do it when we do automated, but then if you go into an organization that's actually manually stewarded in these things, it more often than not, it's 80% that are resolved as the same person. So it actually gives us a pretty good answer to estimate what the remaining number of linkages out there that would be made in an ideal world. And that's what we count as, the false negatives. The things out there that, regardless of what data is in the record, it's two records that should be linked because they're held by the same person. So hopefully that got to it a little bit. And yeah, again, I love pointing through this data. We've got some really cool stuff on that. So whoever asked that question, be interested to have a follow-up and to kind of dissect that in a little more detail sometime. Any other questions out there, Rachel? Or follow-ups on the questions we're answering so far? Either way. We still have you, Rachel?
Hi, sorry. We'll start with for Joaquim. How does this work with a federated model that uses a record locator service instead of an MPI?
Yeah, okay, another good question. So, at the beginning, Nic talked about, and just to set a little terminology before answering that question, Nic described the San Diego HIE as actually being a federated model, and that was federated from the clinical data perspective. So San Diego has a centralized record locator service, but then basically federates clinical data. So organizations can go to one place to find who the patient is, and then request for the actual clinical information, get federated out. So this question, I think, goes to the next level of federation where the MPI locator service actually is federated as well. There's no single central repository. So there's two ways that we kind of fit into that kind of landscape. So one is a little bit changing the game. So because we're a cloud service, we have the records of these people in our environment, which is HIPAA certified and as tight as you can be on security. One answer is we actually can act as a we kind of offer an alternative to the truly federated approach just based on kind of our business model and the way our technology works. The second part of the answer to that is there's a variety of use cases we have, and some of these are outside of HIE, more on the insurance side of things, eligibility side of things, where we can basically help enrich the data so that existing algorithms can make the better decisions. So there's certain cases where we have this
other HIEs that have different MPI setups, or is it just the one? Thank you.
Yep. Yeah, another good question. No, we've done it with a number of HIEs. In fact, we have a couple of these kind of 10,000 record pilots going on right now that are with other HIEs that have other MPI packages today and other HIE platforms today. So we're agnostic as far as what the both the HIE stack, the integration stack, and the MPI itself are. We've got data from other MPIs. It's actually pretty interesting. We had been expecting that we might see widely varying results based on what the MPI is and how they work, and the degree to which they're taking advantage of deterministic or probabilistic algorithms, and maybe how much effort an individual organization had put into configuring it and tuning it and things like that. But so far, we're actually seeing that at least with this stewardship use case, this idea of matching 65 to 75% of the queue, automatically resolving the queue, is actually holding pretty consistent, which is pretty cool. So it's like we're almost seeing the organizations that have a more finely tuned MPI today, or more sophisticated technology or something. Those ones do a good job of resolving tasks, but they also do a better job of getting things into the queue. The ones that might not have as much sophistication built in or investment into the tuning of them, maybe they don't inherently resolve as many, but then they're also not quite putting as many into the queue. So those factors are kind of evening out. So we're seeing kind of a similar impact, regardless of what the incumbent MPI technology is. So it's pretty interesting.
Okay, we're running out of time today. There are a few follow-up questions, but I'd like to connect you guys offline. They're very specific. I just want to thank everyone for joining us today, and there will be a recording that we'll post online, and I'll also send it out to all the attendees. So thank you very much. Bye.
Thanks, everyone. Have a good day.